Good morning, good afternoon, everyone. Want to welcome you all to our webinar, Improving Behavioral Health for Latino Populations, Creating Positive Change. I am Maxine Henry, the Associate Director for the National Latino Behavioral Health Association. Thank you for joining today. Next slide, please. I'm here just to go over a few housekeeping items for each of you. I want to let everyone know that today's webinar will be recorded and archived for later viewing. Please share with everyone you know. A link will be sent out for that recording, and it will also be housed on our website. A copy of a PDF file of today's PowerPoint slide deck will also be available to all of the participants for today's webinar. In order to decrease any outside noise, we will have all lines muted for the duration of the webinar. We will have 2 Q&A sessions throughout the presentation. Feel free to use the Q&A box that is at the bottom center of your screen, or the chat box at the bottom right-hand side of your screen. You can type your questions in there, and then halfway through today's presentation and at the end of today's presentation, Dr. Alegria will be answering questions. Any questions we do not get to, we will follow up and post answers and responses on our website. At the end of today's webinar, we will have a post-training evaluation. Immediately after the webinar, you will each receive a link that will direct you to the evaluation. We would really appreciate your feedback as it helps us plan future training events. Next slide, please. I would like to introduce the Executive Director of the National Latino Behavioral Health Association, Frederick Sandoval. Mr. Sandoval?
Thank you, Maxine. Well, good afternoon to everyone. My name is Fred Sandoval. I'm the Executive Director of the National Latino Behavioral Health Association, and I would like to welcome you to today's webinar entitled Improving Behavioral Health for Latino Populations. This collaborative webinar is an opportunity to showcase the important work of our colleague, Dr. Margarita Alegria, and her research team at Harvard University. I would also like to thank Gilberto Perez for moderating today's webinar. On behalf of NALBA and both the National Hispanic and Latino Addictions and Prevention Technology Transfer Centers, I would like to thank you for joining us today, and please enjoy today's informative and inspiring webinar. Mil gracias. Thank you.
Next slide, please. Good afternoon, everyone. My name is Gilberto Perez Jr., and I serve as the President and CEO of Bienvenido Community Solutions, a small consulting organization that helps health and mental health researchers connect with Latino community across the country. It is a great honor for us to be with all of you this afternoon and this morning. For those of you out on the West Coast, we have a treat for you this afternoon in terms of hearing from Dr. Margarita Alegria, some of the research that's been happening the last 3 years with her team, as they have been focused on improving that behavioral health care for the Latino community. This webinar covers past and current context on Latino health needs, cultural and structural considerations linked to health access and outcomes, and looking at encouraging directions for improving behavioral health for Latino populations. Next slide, please. Dr. Alegria is the chief of the Disparities Research Unit at the Massachusetts General Hospital and a professor in the Department of Medicine and Psychiatry at Harvard Medical School, where she has served since 2004. Dr. Alegria was also the director of the Center for Multicultural Mental Health Research at Cambridge Health Alliance from 2002 to 2015, and is also the former director of the Center for Evaluation and Social Medical Research at the University of Puerto Rico. Dr. Alegria has also been a principal investigator for 4 National Institutes of Health funded research studies and a grant funded by the William T. Grant Foundation. She's published over 250 papers, editorials, intervention training manuals, and several book chapters focused on improving healthcare for diverse racial and ethnic populations. In October 2011, Dr. Alegria was elected as a member of the National Academy of Medicine in acknowledgement of her scientific contributions to her field. So as you can see, we have a seasoned researcher with us today, and Dr. Alegria. It's been my pleasure here the last several years to sit closely with Dr. Alegria and learn more about the work that she and her team are doing across the country in understanding more about how we address some of those Latino behavioral health issues. So without further ado, I will pass the microphone now to Dr. Alegria. If you want to go into your chat box or the Q&A, please submit your questions. We'll start noting those, and then we'll get to about slide 23 where we'll take a short Q&A break with Dr. Alegria, and I'll read some of the questions that you have provided, and she will give us some responses to those. If we don't get to your question, we want to make sure that, as Maxine Henry said, the responses will be posted on the website, and we'll work to respond to those as quickly as possible so you can continue to learn and be engaged with us. So Dr. Alegria, welcome, and it's really great to have you on the webinar today.
Well, thank you, Gilberto, and thanks everyone, Fred, Maxine, everyone that has made this possible. Marie here, Fukuda, and the group at the Disparities Research Unit. I want to welcome everyone. It's amazing that we have such a great group here today, and I'm looking forward to sharing with you what we have learned over the last couple of days. I wanted to take a minute really to just briefly ask for a minute of silence. My heart really goes to all the people that have suffered not only this weekend, but previously on gun violence. And I really ask a minute of silence before we start this. I couldn't really ignore what has happened in our country. And also I want to make sure that I sent a message of unity and compassion in times like this. We really have to be together and unite. So just 1 minute of silence and then I'll start. Thank you all. I'm going to start just covering a few things, and I'm very, inspired by having all of you here. We do our work at the Disparities Research Unit really for the use of people like you. It's really in the use of the information that we generate that we find a passion for keeping on doing this very hard work. I'm going to start just covering very quickly the changing demographics of the U.S., but particularly I want to emphasize some information that maybe seems obvious, but it's not so obvious about the persistent disparities in behavioral health care. I also want to talk about the barriers to Latino behavioral health care that we still continue to have in this country, and with the hopes that, this is a new time. This is a time where we can change the tide and really move and pressure our politicians and policymakers and government figures to really invest in Latino behavioral health care. I want to cover also cultural considerations for all of you that try to do on a day-to-day basis Latino behavioral health. And I'm really grateful that we have so many fabulous clinicians that are day in and day out spending their time in the trenches. And finally, I want to talk about some promising strategies or programs we have done lately to try to improve not only the access, but the workforce for Latino populations. Let me start by the demographics, although I know many of you know about the demographics of the United States. I want to just mention with the projections of the U.S. Census 2018 that we have 320 million people, and it's projected to grow to 400 million. This really tells you that we are a force, and we need to make sure that services are really designed and served our populations. And many of the current services out there many times are not really configured for the circumstances that are for our Latino populations. I know that, people know that the white population in some states are really still the majority, but this is really declining very fast. And especially for children, children are already, minority children or children of color are already, the biggest population. They're already the majority population, and Latino children in particular are incredibly a huge group that we have to serve. Let me just touch, the statistics, the recent statistics, just so you see. And you can see there that 18% of the population in the US is Hispanic or Latino. They self-denominate as that. You will see that other groups are also rapidly growing, and I want to mention Black or African Americans, obviously 13.4, but Asians are a group that is fourfolding in terms of 4 times. They're growing so fast. They're 5.8% of the population, and we have people that self-select also as mixed race. You can see from this projected Hispanic population that the rates are really, really escalating very, very fast. And one of the biggest problems we have in the millions of Latinos that we have in the US is that they're actually geographically located in certain states. And many of them, of the ones that are in states that have limited population of Latinos, seem to be the ones that have the less access. And I'm going to show you some data regarding that. But we have a lot of Latinos that need service delivery and many that are receiving none. Also wanted to talk about language because we don't talk enough about language. And one of my biggest concerns is linguistic minorities that do not have access to services. I want to emphasize, for example, substance abuse care. There is a void, a huge void of lack of Spanish speakers that can really deal with addictions. This is one of the areas that we are suffering the most. But I also want to show you data for the population that's 55 years and older, where more than a third are Spanish dominant. And this requires that we do have services for them in Spanish. Similarly, even among the ones aged 35 to 54, more than a quarter also are Spanish dominant. And there's a lot of evidence. We did a report on the National Academies of Medicine showing that if you don't speak English very well, you should be receiving services in your primary language. So only the people that speak English very well should be receiving services in English language. So let me just quickly walk you through some of the barriers, because I think we need to think about policy making. We need to think about how to change the service delivery that we have today so that it really configures to what people need out there, and show you some statistics that are emblematic of the disparities we have on an everyday basis. You would hear so much investment that has happened over the last 30 years on disparities and disparities reduction. But actually, if you look at the data, and I'm going to show you some data, the disparities continue to exist in behavioral healthcare system for Latinos. And you're going to see it's not only because of lack of insurance, although racial ethnic minorities are the biggest group that has uninsurance or underinsurance, but really it's because we have not eliminated the service disparities. We have not given people something that they're willing to invest the time and effort to go because we make it hard for them. And then the importance of really bringing the voice of Latinos so that the services that we provide are patient-centered, really respond to their preferences, and we understand and approach all these social determinants of health that are impinging on their mental health and behavioral health. Let me start by showing you some data, in terms of the pathway of care. When we look across 10 states, 85% of people can get an appointment with their privately insured and asking for, behavioral health. But it's only 78% of uninsured patients that, can get it, by payment. And if you look at Medicaid patients, that number goes all the way down to 58%, meaning that Medicaid patients don't have a lot of access to care because they're competing with the privately insured population and the population that is willing to pay fee-for-service. The other thing I wanted to emphasize, because this is one of the biggest mistakes we make, is we frequently talk about the determinants that are related to behavioral health service disparities as if they were the reason we have the disparities. They might be one of the mechanisms, but they are not the disparities. And we have to really try to look at what are the interventions that we can do to reduce health and behavioral health disparities. I want to show you some data. This is the quality report, the Agency for Healthcare Quality and Disparities. They do a report every year, and this is their report for 2017. And I want to show you here, because I think this captures what I've been talking about. How poor are the disparities in access? How bad are the disparities in access? And what this graphic shows you is the percentage of access measures for which members of selected groups experience either better, same, or worse access to care compared to a reference group where they actually aggregated years 2014 to 2016. And I want to first show you the first graph because it shows you, to start with, that for 20 of the access measures, on 18, the poor compared to those in high income were worse, and only in 2 were they the same. If you go to Latinos, in that, which is the last column, you would see that of the 20 access indicators, Latinos were worse in 14. They were the same in 3, and they had only improved in 3, meaning that in 70% of the measures, Latinos are experiencing more access to care. Next. So I want to show you, obviously, insurance is an area that is every day being under scrutiny. But I want to show you how, if you look at the gray column, it's true that there's a lot of Latinos that have some insurance. But if you look, private insurance, Latinos are the group with the least private insurance, 52.4%, compared to 73.9% for non-Latino whites or 74.2% for Asians. So many Latinos are in employments that do not provide them private insurance, and therefore many of them, 40%, are receiving government insurance. There's also systemic barriers in terms of lack of diversity in leadership and lack of low provider diversity in many agencies. One of the problems that people now are confronting is we didn't invest in training sufficient number of Latino behavioral health providers, and therefore we have lots and lots of areas that are really not well, do not have access to a good provider diversity for them to choose from. The other thing is, even for the ones that are not Latinos, but that are culturally and linguistically competent providers, many of them, are hard to find and have incredible waiting lists. For example, here in Massachusetts, we have one of the biggest Latino clinics, but it has a waiting list for behavioral health of between 3 and 4 months. There's also service silos, meaning that if you want to go and get resources, not only for your behavioral health, but you have other medical problems or other social problems, you have to go to many, many agencies because all the, everything is a service silo. So the idea of having a one-stop shop where people can get everything in one visit is still far from reachable for Latinos. And then you'll see that there is in certain areas, we had a lot of investment in care, but in others not, and that geographic availability is very, very limited. For example, a place like Vermont has very limited availability for Latinos working in the farming district. Or in frontier areas, some people are saying that the demand is so huge that they don't have enough capacity to serve. I also want to talk about the geographic disparities because, you know, if you think about it, having proximity to available services, especially with public transportation, especially with, you know, being able to move from your work to the visits makes it incredibly hard. For farm laborers, we know that they have long hours of work. They're isolated in neighborhoods, and this really, you have to think about different configurations to service them. And this is what exactly we're trying to do. How do we service people that are in their jobs, having limited time to get services, that work 2 and 3 jobs on times? I mean, overall, I think the biggest problems that we have to think about from all the way from policy to all the way to training and workforce development. For example, the limitations of Medicaid payments make it very hard for many behavioral health providers to do that job. So many of them move to administrative jobs, but this is where trying to move policy from Medicaid to Medicare payments to the level of Medicare payments, it's a critical one. And we've stated this in several of the reports that we have done. The other issue, like I say, is the multilingual providers, and we have also talked about the importance of maybe having opportunities for Latino Spanish-speaking providers to serve not only in the state or county where they're licensed, but the possibility of expanding licenses to other areas like are done in the Veterans Affairs, so that people could receive services throughout different places. And then, you know, limited provider options because people are not willing to accept low payments. So what we are seeing is that people, even if they don't like their provider or feel that the services that they are receiving are not, you know, adequate, they don't want to drop their provider because their options are so limited in getting good providers or getting adequate care with sufficient appointments. And one of the patterns we're seeing lately is this pattern where people are being seen every 2 to 3 weeks, which actually, in our experience, is problematic because people don't have enough time with the provider to feel that their stress and their anxiety are dealt with. And finally, we have a lot of low quality, limited access because there's not sufficient investment in training and in offering good opportunities for social mobility for the workforce. I also want to talk about delays in treatment. There's really good data showing that people spend around 8 years before they start thinking about going to behavioral health. So the idea that we have to wait for people in the clinic is just way gone. We really need to start doing a lot more screening, so that we can identify people, even people that have somatic interpretations of mental illness. And I wanted to show you, and I'll show you later in more detail, but one of the biggest problems, of the biggest barriers in our Latino communities is that the perception that mental health services are not going to work for them. They're not going to help them. So we have to change that perspective, that narrative that behavioral health can help you, particularly the sooner you get it, and talk about more about how that stigma, especially among our elder Latinos, we see a lot of stigma. So one of the things we have done is show them testimonials of the importance of receiving behavioral health and how it's very different than what they expected. Fears of confidentiality and hospitalization are one of the things we keep hearing more and more. People being worried that if they report how they are doing, they might get hospitalized or they might lose their chances for citizenship. And as always, we see a lot of discomfort in talking about emotions and talking about their personal circumstances. But this is where we can really do an incredible job of engaging people, making sure that people trust us, feel comfortable, feel that we are going to be confidential, that the information that we're going to provide and the services are not going to be reported to others. So I also want to talk about continuation, because one of the biggest problems that we see in people dropping out of treatment has to do with the interpretations that what people are getting is not really worth their time. We hear this over and over again, and so it really means that we should be checking, particularly us, all of us as clinicians, who are the people that are not coming back to care, and trying to figure out why are they not coming to care. Is it our communication? Is it the way we're talking to them? Is it that they don't feel we're being private and confidential? Or is it our relationships with our providers? That types of relationship of trust require a lot of investment, and they have a terrible cognitive demand on providers to make that relationship. I want to say that we published a long time ago a paper, not so long ago, but a paper talking about that the biggest issues that come to play. And as I said, thinking that treatment would not work is really a big one. The desire for people to handle the problem on their own. A lot of people feel that they can handle the problem on their own because they have done so, and in many circumstances, the problem has subsided. But we have to tell people that learning coping skills and learning how to deal with stress, and especially toxic stress that we're receiving on a daily basis, and how to have better coping mechanisms is something that they can learn, not for today, but for always. And then obviously being unsure of where to go, where can they get very good referrals that are going to be open and willing to take them. So I think one of the biggest problems we have mentioned consistently is the idea that the system is really very much configured for people to be on a face-to-face engagement, and that's really not necessarily possible for many of our Latinos. So we actually believe in aggressive outreach, where we go to social agencies, and rather than waiting for people to come to the clinics when they're quite ill or feeling the consequences of untreated mental health and substance problems, to actually try to see if we can reach them, contact them, and follow them more intensively. This requires a lot of investment in engagement and outreach, and this is one of the areas where a lot of our behavioral providers are not paid sufficiently. But if we don't get people to go at least between 4 to 6 sessions, we're really wasting the time of both the patient and the institution, because there's not a lot that can be done in just 1 or 2 sessions. So I'm open for questions. I would love to hear what people have to say and questions that people might have for me now.
Dr. Alegria, thank you for the wonderful, information there. There are some questions that have come through, and I'll go ahead and read through a few of them and then have you work to answer those. The first question comes to us from Olga Rodriguez, and she writes, how is the faith community helping with this effort?
That's a great question. I think there are many, many places where the faith community is helping in terms of both some parishioners that have become some priests and some rabbis and that have really gotten trained. For example, I went to one of the places, Centro Sol, and some of the church leaders there were really starting to get trained on how to provide services. The same thing for Catholic Charities. They have people on the faith that are trained. However, I think not everyone is willing to go to parishioners, and some people feel that, it's a different approach. So I think it has to be someone that ideally can help in the sense of spirituality, but also help in the part of making sure that you are able to provide coping resources and provide mechanisms that might help the person do better in terms of their mental health and addictions.
There's a second question that comes to us from Massachusetts and from Juan Bui. Talks about how parent community engagement plays a role here and if the class national standards have been implemented, and how does working with a limited diverse workforce help in all this work?
So the class standards, one of the biggest problems we have with the class standards is they are really not enforced. So in many, many areas, for example, I know are more knowledgeable about some of the areas like even New York and Massachusetts, but actually I know about Maine and other places, and I can tell you that the standards are not being enforced. So in many places, although they say they have to have them, it's not necessarily that they do have them and that they're available. So we hear about people having to wait for an interpreter for a long time, and they just can't afford wasting the time. So I think the class standards are not. For people that do not, this is where I'm going to talk a little bit about having the opportunity to work with community health workers as an alternative to have a Spanish-speaking population that can be the bridge between the professional and the patient.
There's also a third question that asks if you could maybe give an example or two of the difference between determinants and their disparities.
Sure. I think, for example, I would say housing, for example, is a huge determinant, social determinant of mental health and well-being. One of the biggest health determinants, for example, for children has been food insecurity, for example. We did a paper showing that food insecurity is one of the biggest flags for children that might have problems later on in terms of mental health and substance abuse. So those are problems that are related to the disparities, but they're social determinants that are not necessarily the disparities in behavioral health care. They are what you would say hand in hand with problems that might affect how people have behavioral health problems, but they're not necessarily the disparities, explaining the disparities in service problems for behavioral health. So for example, the problems in behavioral health might be related to institutional racism, or it might be related to the lack of providers that are Spanish speakers, for example. But housing obviously is going to have an effect on the impact of behavioral health of that patient, but it is a determinant. It's not what explains the behavioral health service disparity.
We'll go with a few more questions here. Paula asks, do you know how this is implemented in Florida? She kind of sees a lack of services for Latino families, especially in Spanish. And we also have a question from a person out in New York, where there's been about 600 million investment into a lot of Latino mental health services, but I've been disappointed with the response to that and wanted to know if from Florida all the way to New York, are there things that are being implemented, and how do you see responding to those potentially lack of services?
Yeah, I think there are things people are trying to do. There's no question. I don't think they have been as effective as they expected, both from New York and Florida. For example, what we're finding is a combination of things, because people have had bad experiences in some of the institutions, and they are not treated necessarily with respect or treated nicely. Some people are just not even looking for services. This is where I'm saying that outreach and actually, bridging to community health workers or promotores de salud that can take the word that things are changing. This is what there is, talking about, behavioral health literacy. So our populations really see what's out there, what's available, and how to navigate with them. I think the general concept of doing things without thinking all the steps and scaffolding, making sure that you have the linkages between people getting trained, people knowing how to outreach those populations, people knowing how to service it at a time that's convenient for them, on weekends, at night. You have to do a lot of accommodations to make whatever new services you're providing work. And you have to help people navigate a very complicated system that's really not well suited for the lives we live today. So I think one of the problems we have is the healthcare system has stayed in the 60s and 70s, and we are now talking about, 40 years, 50 years later, and the system has not started being done in a way that complies with what we need today. So that's where I think that we definitely could do better for our Latino populations, and those are the sorts of models we're trying.
We'll go with maybe two more questions, Dr. Alegria, and then we'll get back to the presentation. And then for our attendees, I am responding to your question by saying that we are in Q&A, and we will get to your question, whether it's at the end of the presentation or actually through all the responses will be answered at some point, and those will be available on the website at the National Latino Behavioral Association. So please keep sending your questions, and we'll work to get them in right now, but then also at the end of the presentation. One other question, Dr. Lydia, that comes through is the idea of suggestions on this language line when no interpreter is available, and sort of the effectiveness of those language lines.
So, like I said, we did this report that's actually in the National Academies of Medicine, and I'll try to send a summary to all of you. It's not very effective is several things. I mean, one is people have really shown that having family members translate is not a good idea. There's a lot of evidence of the distortions and omissions and how people really distort some of the data that's giving, particularly in behavioral health. We've written 2 papers, and I'm happy to send them around. But there's quite a lot of evidence that it is problematic, given that you don't have that choice, given that that's not a possibility. I mean, people are using telephone translation and interpretation. If you can get it fast, it is helpful. At least it is the evidence seems to show that that's way better than trying to do an ad hoc translation. And second, I mean, the other alternative that we are proposing is what people have done in Canada and in other places, which are what they call cultural brokers. And those cultural brokers are people that are from the community, know the population, and can do a fairly good interpretation and translation if they are well trained. So that's the other model that has worked out better than just having someone try to do the very best they can. And one thing I should say, you know, I've seen in many cases people saying they really are fairly fluent. And when we videotape them and show them how the patient is struggling as they go through what they're doing, they see themselves how difficult it is for the patient in trying to sort out, you know, and interpret what that provider is saying, although the provider thinks they're doing a fairly good job. So I think if you can, videotape or audio tape yourself and see the struggles that your patients are having.
I'll ask one last question, then we'll have you continue with the slides, Dr. Alegria. And that question comes that says, can you speak a bit about the role of racism among our communities and how we look at data without taking into account the diversity within our Latino communities? And this person, Gabriela Betancourt, gives example of health disparities between Afro-Latinos and non-Afro-Latinos.
Mm-hmm. I think that, you know, the way I really appreciate that question, especially, you know, what we're confronting and how people think about it. And so here's what I would tell you. We actually work very, very much on customizing what we're offering to the patient. And we talked about, you know, making sure that I think you avoid racism, you avoid a lot of attributional errors. And attributional errors is when you attribute to people characteristics or, you know, you tend to say this person is so-and-so when you are actually don't know and you don't check whether your attributions are correct or wrong. For example, a patient coming in very late to a session, where you could say this person is really disorganized, is not motivated, because you haven't asked what happened to that person and can I help you, you know, figure this out so we can have more time for the session. So attributional errors and biases and stereotypes that are so common that we do, and I should say everyone does this, but I think the area of trying to show to the patient, one, that you are really focused on engaging with them, on trying to understand who they are. And it's not just race and ethnicity. Like race is obviously a very important aspect, but don't leave it, if you think it's really the elephant in the room, raise it to your participant or patient and tell them, you know, I want to really make sure that I'm not making attributions to you, or that this is really fulfilling your preference, or what are your expectations. So we tend to customize very much to what the patient wants. And the way we do that, every single session, we ask them, what is your agenda for today? Is there anything you want to make sure that we discuss today? Are we going on the right way in terms of progress? So we try to customize very much, and then we discuss issues about, you know, racism and issues about people's mistrust in the way we talk to our patients to make sure that they understand, you know, we're gonna do whatever it takes to make sure that you feel safe and comfortable and we can give you a good service.
Thank you very much. If you can ask Marie to continue the slides, that would be great. And then
Sure.
For our attendees, we will have continued to jot your questions down, and we'll work to answer as many of those as we can toward the end of at the end of the webinar presentation. So thank you very much for being engaged. This is what it's all about. So thanks. Dr. Alegria?
So, great. So thanks for those wonderful questions. I mean, I wish we were in a room together because there's a lot that could be said about this, but I'm going to talk about some cultural considerations for trying to deal as much as possible with the challenges we have when we are trying to offer services for the Latino population. And so there are a lot of things that people can do. You don't have to be Latino yourself. There's a lot of things that we train for example, the clinicians that we work with, they're not necessarily Latino, and yet they can offer good services. One, they're very familiar with what are the cultural conceptions that people have of mental health and addictions. They've really learned from, being part of that population, or really doing a lot of the previous work so that they get immersed in the culture and the routines of Latinos in their community. We try to hire and support bilingual, bicultural behavioral health providers every time we can, but we also, if not, then we try to make sure that the English speakers then serve the population that is fully fluent, and not try to put people that are not really fluent, because what we see is that if that's the case, we tend to see them quickly drop out, even with quite serious conditions. We try to select interpreters that know about mental health and substance abuse. We find that when the interpreters are really interpreters that are mostly of medical conditions, they tend to change some of the wordings of feelings and of emotions, and that's where we see some of the distortion or the omissions. And for example, that has been happening in some of the suicidal cases, or cases where you actually need someone that is an interpreter that really works with mental health and substance abuse. The other thing is to try to see if you can work together with primary care providers. Most people have combined, the co-occurrence of both mental health, sometimes substance abuse, and sometimes medical conditions. And especially some of the medications, it's really important to make sure that you're working in a collaborative fashion with the primary care. One of the worries we have lately is that we're seeing quite a significant number of Latinos saying that they don't want their primary care provider to know about their mental health or their substance abuse. And for us, that raises the issue, what's going on, that they don't trust their primary care providers and other personnel in the hospital. And it sort of raises the issue. We need to change our institutions if that is the case, because it means that people are not going to have, a holistic treatment. The other thing is we all of us, and I include myself, really want to use, traditional healing practices. And I think that speaks to whether people want to use yoga, want to use meditation, want to use acupuncture, want to use, remedios, to help themselves, a good diet. So we actually believe in the immersing and infusing whatever we do in behavioral health together with other things that people are doing. This also touches on what one of the first questions that was asked about faith. If faith is something that really is helping you, that should be part of your bundle of services and should be an important piece in helping you cope through life. I also think things like psychoeducation we use in what we're doing right now. We do a lot of psychoeducation, not only about the symptoms of behavioral health and substance abuse. We do a lot of psychoeducation about sleep, because sleep is so linked to mental health. We talk a lot about diet, about how the food that you eat is really related to how you're going to feel and to your emotions. We talk a lot about issues that have to do with how to look for resources so you are empowered about your condition and you know how to look for, are there going to be side effects in the medications that I'm taking? You know, we send them to websites so that they can identify side effects and really select the best websites that are there for finding about their illness. And then another thing we have done more and more lately is home visits. And we find that home visits is a way to get to know the person, you know, in a more close way, in the sense of sometimes, you know, knowing, you know, what can the person really go for a walk in that neighborhood? Are they really isolated? What are the conditions under which they live? And also for the person to see how much we care about making sure that they receive the services. I'm going to talk very quickly about this, and I'm again happy to send you these articles, but one of the other practices that we recommend is that people adapt the treatments and not use manuals that have not been adapted or well adapted. We see a lot of people trying to improvise with manuals, and it doesn't necessarily work. And the person gets confused and is trying to, at the same time, do the translation and at the same time explain, you know, the different strategies, and it just doesn't work very well. I also, one of the things we're also doing to deal with these practices is we're combining not only giving people, for example, to give you an idea, not only the behavioral health, either mental health or substance abuse, but we also include other medical things that we can advance for the person, be it, you know, sexually transmitted diseases, testing people if they think they're at risk, helping people connect to primary care providers if they're having chronic pain, you know, working with people that are in employment so that we can really make sure that people get connections expanded and resources are more in their radar screen to improve their lives. We also do a lot of social marketing, you know, in how do we, you know, with people having so many demands today and time being the biggest luxury. It's not money, it's time. No one has time today. People are so worn out that you have to convince them to invest time. So you need your elevator speech, your 3-minute elevator speech that you can tell a person of why they should be coming to care, what should they be investing, and also why would they want to invest? What would be things that would make them come to that next appointment, and what are the changes they want to see, so they have to visualize it. We use a lot of family members and patients to tell us how to improve what we are doing. So we are constantly revising, you know, our interventions to make sure they work. And we're making sure that the people that are providing our interventions get constant training. So when people tell us, you know, people are asking us about medications that might work. Well, we clarify, no, we don't want, unless you are a psychiatrist or a primary care provider, to be given, you know, information about what people should use, but you can give them information about these are things you should know about medications and help them produce, for example, a pamphlet. Or if people need information about, you know, insurance, again, we try to see what can we find for them, or legal issues, the same thing. We try to create materials that might help in terms of helping the workforce, help our populations. One of the things we're doing a lot is telephone counseling. You know, we're finding that especially for people that have good hearing, have time that they can devote to telephone counseling. We sometimes do some of our services, you know, by phone when people are on their way to work. sometimes where they're at night preparing, cleaning, washing dishes. You'd be amazed how much we can do and how much people can do while they're, in the bus or sometimes even in the train. So we found that we actually did this intervention and randomized people to the telephone or in-person psychotherapy with the clinician in the phone. The person never saw them in person. And we actually found that the intervention worked the same. And in addition that it worked the same, we found that the rapport and the trust was exactly, there was no difference between the people that were treated on the phone or in person. We also try to make sure, that we develop interventions and services that are evidence-based for Latinos. Unfortunately, you should find out which are the treatments that have been culturally tailored to treat our Latino populations and which ones, have evidence that they work. There's quite a bit of data suggesting that many of the interventions that were developed for non-Latinos work well with Latinos. But we find that the cultural tailoring, and there's evidence of that, seems to be more tied to good retention in treatment. And then how can we improve the workforce for Latino populations? So we've spent a lot of time, I would say, doing 4 types of intervention over the last, I would say, probably 8 to 10 years. We do a lot on patient-provider interaction. How can we improve the patient's level of activation and shared decision-making so that they feel they play a central role with their provider? How do we as providers make sure that people feel like they are the experts on themselves and are willing to make decisions of their treatment? There's a lot of evidence. The Agency for Healthcare Quality has shown and invested more than $150 million in shared decision-making interventions because they show that people do much, much better in terms of their satisfaction with services, their retention in treatment, and actually it improves also their outcomes. We just got published a paper showing that it also decreases people's level of anxiety if you allow them to do shared decision-making and help them be part of the co-creators of the treatment. We also do a lot on trying to improve providers' competence of evidence-based care or evidence-based practice, particularly things where they can work collaboratively with the primary care providers, where they have assertive follow-ups, flexible appointments. But also we try to see how we can train providers to feel competent in these new approaches. These new approaches require practice and require an investment for the institution on doing them. And I'm happy to talk more either in this webinar or in another one. We also have to do interventions in the community. For example, right now we're developing an intervention for youth that is done in the community because we see so much negative effects of our youth, our Latino youth, that we are seeing that we can do an intervention that actually helps many more youth, especially youth of color, if we do it as an intervention in the community. And also we are trying to expand the capacity in community agencies so people don't have to go to the clinic to get care, but actually get treated or get services and coping skills and strategies in youth organizations, get strategies in community organizations that serve the elder. And finally, one of the most important things that we need to move our agenda is to policymakers. I'm actually presenting to policymakers this month on the importance of addressing the disparities there are in behavioral health for our communities. how they need to collect data, how they need to really understand market forces so that we can improve service delivery. One of the things, I think people have spent a lot of time saying how we need to change what people do, how our Latino patients, deal with addressing their services and their needs for services. But I actually think that it's going to be hard if we don't do more for our provider organizations. We need to get providers cultural awareness about how they need to be coached, how they need to get institutional support and supervision to make these changes, because they're not trivial. These are very demanding changes if you want to address disparities. I think we need to get payers, both federal, state, and private insurance payers, to really pay for the technical assistance that's needed if we want to train and support our organizations. I have to say there's a lot that could be done if people actually, for example, look and see if they're in a designated health professional shortage area, because if you are in one of them, then you can get more resources in terms of, getting funding for training, for workforce development. So if you can find whether you are designated in a health professional shortage area, it's something your institution can do to get training and technical assistance. I think in terms of, I just wanted to show you an example of one of the projects we're doing on building community capacity in our agencies. This is, one of the areas we were interested in doing is making sure that our minority elders, specifically Latino and Asian elders, really receive services, and they don't come to services. The stigma that elders have is terrible, so it's very hard to get them to services. And yet, mental disorders represent a huge global burden of disease, and it ranges between the third or the second cause of disability for elders. And if you look at the data, at least 20% of our older Latino adults have one psychiatric or substance abuse disorder, and many of them are not being treated. It's true that Latinos have lower rates of mental health disorders than whites, but it is also true that when they experience any of this mental health or addiction disorder, they demonstrate greater severity, persistence, and recurrence of symptoms. If you look at linguistic minorities, this is even worse. 90% of linguistic minorities with mental health conditions get no treatment. 66% of older adults with major depressive disorder, these are not only linguistic minorities, but in general, receive no treatment. And 72% of older adults with anxiety disorders also receive no treatment. When we did a study a while ago, we found that only 1 in every 10 received what we thought was at least the minimally adequate care for treating their depression. So even in something like depression, very few people are getting treatment. So in Positive Minds, Strong Bodies, what we're doing is we're training the community-based organizations that serve this minority and immigrant elders. Actually, in this study, 70% of the elders were immigrant elders. And we provide them with a combined intervention that includes, 10 sessions of cognitive behavioral therapy that are individual, given by a community health worker, and 36 sessions of exercise over 12 to 14 weeks. And the CBT is based on an intervention we developed for Latinos and adapted it also for African American and Chinese elders, and also adapted it so it could be provided by community health workers. The strong body is based also on a rehabilitation intervention that is resistance-based exercises to build strength and improve mobility. And this, we train exercise trainers that were actually, or people in the community-based organizations that we trained. The idea was to get people that are showing signs of late life function and disability to do better, because all of this affects, you know, your performance of expected life tasks, but it also will have an impact in your willingness to socialize. And what we found with this intervention, we had just finished it. I didn't put the numbers here, but we found that the intervention was extremely successful in lowering self-reported disability compared to the control condition, and that people improve on their mood symptoms, but not so much on their generalized anxiety disorder in comparison to the control condition. So as you can see, one of the things we're doing to expand the Spanish, especially the workforce for Spanish-speaking Latinos, is we are working with community health workers that can become our frontline public health workers, that can do the outreach, the community education, can do some informal counseling, provide social support, and be the advocates for our Latino populations. They also serve as liaisons for social services or other services. And there's a lot of movement. Now 16 states, if you see here on 2016, are offering, you know, to remunerate or reimburse, you know, community health workers. So you should find if in your state that's a possibility. And then working with community health workers, we've convinced, for example, the hospitals, and now are working with the accountable care organizations to try to convince them on the investment on community health workers to bridge with clinicians and primary care providers on offering better care. This promotores de salud help to educate about resources, you know, can help address unmet needs because they know the community, what's acceptable treatment, how to empower our patients, and what makes sense to offer the patients given where they are and who they are. And then they can help make the healthcare system more responsive because of what I mentioned before, being siloed and not really offering great services. And then, you know, they can be the persons that can reduce the barriers. They can integrate people not only by their language, but by knowing what can be culturally matched to our populations. They can be linking the neighborhood to social services, and they know how we have to present some of the problems so people are willing to engage with us. I'm going to end up with the patient-provider encounter study because this is a study that we did. And I want to end with this because it's so important not only to invest in the clinical and technical aspects of care, but mostly where I see people falling through the cracks is in not having a connection with their provider, not really feeling that their provider, that those interpersonal factors matter to the provider. So it's really, we talk about listening, understanding, and managing differences, but it's really paying incredible attention to what the patient wants and making sure that we are an instrument of hope and positive change. Very few providers today talk about hope, talk about how can we change the narrative of your life to make sure that you're successful and that you can, you know, really move forward in all the things that are having an impact. We can change some of the circumstances, but we can change how you feel about them and how you cope with them. And that's what we want to, you know, work with our Latino patients. We have done a lot of work on an intervention called Decide, which is how can we possibly positively influence patients to think about their activation, about telling us what they want, and engaging them and retaining them in care. I'm happy to talk about that. And the other one that we have really worked a lot is in shared decision making, as I said. That is more for the provider, how Latino or clinicians that are working with Latino populations can get trained in shared decision making to make sure that they bring into the clinical visit the preferences of the patient, but also what is the view, the framing of the problem that the patient has. So for example, we use a lot of cultural formulation, learning who the person is, what matters to that patient, we can listen to that person, what are the things that might move that person to stay in care and come to treatment on a weekly or bi-weekly basis. And then how can we engage with them on a personal level so that there is that connection? We did this trial and we found that yes, we can definitely, it's in JAMA, this trial was published in JAMA Psychiatry. And what we showed is that yes, we can coach providers to be more willing to do shared decision making, to really not do attributional errors, to empower patients to feel more comfortable and being collaborative in their care, and to make sure that we show providers how they're silencing their patients so that they actually stop silencing patients and actually empower them more. So I'm open to questions and any comments people might have.
Thank you, Dr. Aguirre. There are a number of questions that participants have been asking, and they seem to be on a number of levels, but I'll work to put some out there. There does seem to be a continued question around the telebehavioral health to address the issue of access. Gerardo from Puerto Rico is asking that particular question, and another question in terms of access to or engaging the elders. Do you think that outreach is important in the engagement process, especially with those elders? So if you could maybe
Let me start with that. Yeah, with the first one. And I have to tell you, Gerardo, that we actually tested the same intervention in Puerto Rico, and it worked, almost the same as it did in Boston. So it is an intervention. I'm happy to give Marie all of this paper so you can see it. But what we found is, yes, people did actually quite well when we did the intervention by phone. So we could offer people the intervention by phone. We develop a manual that's easy to follow, but people need to get trained and supervised to do it well. But if you get trained and supervised, people can do this cognitive behavioral therapy by phone in a very, obviously we coach you on how to do it by phone, how to make sure that you maintain the interest and motivation, and it's very interactive so that the person's not, completely off and doesn't follow you. And then it also has a workbook. And we also send information to the patient about the areas that were discussed, so that they keep this little newsletter to remind them of the coping strategies that we're teaching them. And most of what we do during the session is trying to practice what we are actually coaching patients to do. So it's very doable. Yes, regarding the second, we definitely have to outreach our elders. Latino elders. We were really surprised how many elders, in doing this in both community, we're doing it in community agencies and also in clinics in primary care for people that are not going for behavioral health. And we're finding about a third of them that are actually should be receiving some sort of mental health service. So a pretty big number in both community agencies and people that are in clinical, going for primary care. And what we found is, yes, we need to outreach them because the lack of understanding that there are things that could be done, that you don't have to suffer in silence, and that these are not things that you should be, having in life, and that these are mental health or substance use, and that we can give you strategies to make sure that you get out of them. It's needed. So that's why we think outreach is so critical for this population.
Thank you. There's also another question, I think, related to some of what you're talking about, relating to the culturally adapted and culturally tailored interventions. And one of the attendees asks about, often there is that substantial pushback against the use of those interventions. And a lot of times what they're asking is the typical argument relates to fidelity issues, despite research-based and practice-based evidence that actually demonstrates positive healthcare outcomes. And the attendee asks is, how do you respond to the fidelity argument?
So what I would respond to the fidelity argument, this is a great question, and one that we constantly, I have to say, have debated in our teams and debated in the literature. And what I would say is there are two aspects to the fidelity. One is when we are starting to test an intervention, we need to make sure that almost everyone is doing it fairly, similarly, just to see that the intervention is what we're saying is the intervention. However, that is the phase of developing, testing the intervention, not of implementing it in real life. And in implementation, it's the opposite. You want to try to see, there has to be some level of fidelity, but that's where we want to see how do you need to change the intervention so it fits in that context. We have to make changes to the intervention so that it really is effective to different populations. Let me give you an example. When we were doing that study that I was talking about, the elderly, we actually found that the communication module that we were covering with our participants worked for Latino populations, worked for African American populations. It didn't work very well for Asian populations. And initially, the community health workers said we actually should drop it because that's not going to work for Asian populations. When we talked to the supervisors, they said, no, actually, because communication, open communication, and really making, confronting conflict is so, Asians are so avoidant. We need to expand that session to 2 sessions. Or, we have a lot of changes that we have made to the actual intervention now that we're going to a phase of implementation, because people have said, this session, you have to drop this out, our clinicians, because this is not, people are not getting it. We have to do it in a different way. So we believe a lot in getting iteratively adapting the intervention to make sure that the fidelity is not completely off, but really we are open to making changes that are going to improve on the intervention. However, I have to emphasize that there's evidence. For example, in one of the trials we did for Latino immigrants on co-occurring mental health and substance abuse, we found that the people that actually had the best outcomes were the people where providers had followed the intervention with more fidelity. And the ones that had not as good outcomes were the people that were doing more changes to the intervention. So you have to find that balance of something that's doable and people can implement it well, but at the same time that it's not so far off from the original that might not really prove as effective.
Dr. Lydia, we thank you for the good work of answering questions. There are more questions that are coming for us. So we will continue to ask you questions. There's a person that's asking, Yirka Platt is asking, what's your opinion about having emotional peer support programs as an opportunity to reduce stigma around mental health, and also opportunity to be more open to the idea to start counseling therapy with Latino clients?
I love it. I really love it because I think peers can be better ambassadors of when, how treatment can be very efficacious and helpful. So I actually am very much in favor of peer support and peer emotional support, especially because I think that if you don't have, it takes a village for many of the chronic conditions for people to get better. So having peer support, well-trained peer support, staff that gets paid and where this is part of their job, to me would be a tremendous asset.
There's also another question that talks about this idea of, are there simple models for doing a community assessment in our county? See how Latino behavioral health metrics here differ from national trends. Is a community assessment worth the time, or should we dive in with other first steps? And how do we measure our own capacity to address Latino behavioral health needs / disparities?
That's such a great question. So what I would say is you can get a lot of the disparities in your communities by looking at a combination of things. And I don't think it's necessarily a waste of time, but I also think it requires some resources. The first I would say is claims data, or if you work with you can work with institutions that allow you to work with claims data. It's a way to look at what's happening, who is getting care and who's not. For example, I once saw, I'm not going to say from what system that I work with, retention rates for patients after their first visit. And I was appalled at how clear was the disparities in people not coming back to a second and third appointment. It was like 40%. And so, you could look at data as claims data or system level data that gives you a snapshot of what's going on. I also like the second thing that I really like is the secret shopper. Sending people that are not identified as patients and trying to see what is the care. I once said, and I'm always thinking that I would like to do a study where people actually rate their providers, but in a very simple way to try to encourage providers and patients to be more aware of how good or bad is the treatment they're getting. So I think there are ways. I like the idea of doing this needs assessment, particularly because it could be done not so difficult. It wouldn't be so difficult. However, I really think you should use the assessment for benchmarking. And benchmarking meaning that if you want to do an intervention, for example, if you want to do something different, that you collect data and then that you try to see that what we tried changing, did it have the impact that we were looking for? Because sometimes it doesn't. It really doesn't improve service delivery. We've done it in some hospitals or systems of care, and they have transformed the system. They really have transformed the system because then everyone is aware that, they know where are the faults in the system, and everyone is working very intensively with them.
There's another question, Dr. Lydia, that comes that says, have you assessed any efforts related to the current immigration policy trauma that is being experienced in our community, and how communities can assist to abate substance use or mental health episodes?
So we are seeing in our communities a lot of anxiety, uncertainty, and a feeling of lack of safety. I mean, this is self-reported by people. This is not, we don't have a quantitative assessment of it, but it's coming over and over again. We also hear it from youth in the community. And I think this issue of lack of security, lack of safety, it's having a toxic impact in people's mental health. Yes, I think there are things we are doing. This is where we are trying to work, for example, with certain community-based organizations on trying to build capacity in those organizations to actually serve as the bridge to try to at least offer something at the community level, and then if necessary, do referrals for more serious episodes. But I think we need to do more to pay for those services and really build the capacity of those community agencies to be on the vanguard with everything that's happening and to be the buffer, helping the buffer of what's going on, because I think there's a lot of suffering and insufficient resources.
There is a question here that talks about many Hispanic cultures prefer to rely on cultural teachings of their ancestry for their healing, such as spiritual, herbal, and even community-based methods. The attendee, Alina Johnson, is wondering, how can we better include these cultures' beliefs in a system that has been shaped so strongly by Western medicine and often even frowns upon holistic and functional medicine? And this, you addressed this a little bit in the presentation, but our participant would like to just a little bit more in depth on that.
Yeah, you know, one of the things I'm really glad you raised that. We actually think ethnic identity is such a strong anchor for people's mental health. Really, really a strong anchor. We particularly see this in youth, where having a strong ethnic racial identity protects you from many negative outcomes of mental health and substance abuse. There's quite a bit of data already coming out on the importance of racial ethnic identity. Using, like you're saying, going back to our roots to, you know, we use a lot of sayings that we have forgotten that people used to say in our communities to remind people, we call it dichos, and we have the same in African American communities. They're like pearls of wisdom that people used to transfer from, you know, from your grandparents to your parents to your children. And we have completely eliminated those, but we try to incorporate them in some of our treatments, because they were there for a reason. People remember those dichos when we introduce them to our interventions. And we also are more and more trying to reinforce two things: the ethnic identity and how you feel about your social position in your community. And that, you know, we're moving towards civic action, civic engagement as a way to bring your voice into what happens. And then we're also trying to work a lot more with making sure that people feel that their cultural background is important for their health and their social relations. So one of the things, there's a lot of evidence, I think this is a very important point. There's a lot of evidence that people that live in ethnic enclaves or racial enclaves sometimes do better, you know, than people that are in very isolated neighborhoods where they're one of the few. So
we do have time for probably a couple more questions here. We are really about 2 minutes from having completed our webinar. So it has been wonderful to hear from folks. I'm wondering, there's a question here from Devon Corpus in terms of just talking about how do other agencies make treatment accessible for those with limited financial resources, i.e. no federal assistance, no private insurance, no sufficient income to cover services. Is there anything out there that you might know that how do agencies make that treatment accessible if they don't have those types of things?
Yeah, it is very, very hard. So a few things. What really is covering that fault, that gap, are the fairly qualified community health centers, but not everyone has access to them. But actually, that's where people have been, in many states, have been received treatment without having, for example, we work with people in North Carolina and in other places where that's where they're actually getting their services to try to, fill that gap. However, the waiting list and some of the resources are limited. This is where we think community health workers, and building capacity in community health with community health workers and promotores that are supervised by clinicians, by licensed clinicians, can really help us expand the workforce. And then trying to see in certain places they are already reimbursing for those services as a way to expand how many people can get treatment with limited resources. And then the last thing is what we are trying to do is build it in community agencies that through prevention and through certain programs like chronic care can bill for some of those services, even though they're in community agencies.
And the final question that we'll ask is has there been any work done with DECIDE and applying it to sexual health and sexual and reproductive health decision making within the Latino population? And once we complete that question, I'll just have a little bit of housekeeping and reminder on the questions that people have asked.
So we have not exactly done it on sexual or reproductive health, but it is something that could be easily extrapolated to sexual and reproductive health, because it's really, some people are trying to use it for HIV treatment. Some other people are trying to use it for PrEP. Some other people have used it for domestic violence and trying to work a better relationship in bringing the voice of people. So it is very, it's usable. If you go to JAMA Psychiatry, you can download it. And if by any chance you don't have access to it, we're happy to share the information with you if people don't have access to JAMA. But it is something that could be very easily used for reproductive sexual and reproductive and sexual health.
Thank you, Dr. Alegria. The presentation has been fabulous, and I think the participants have benefited greatly from the presentation, but also I think the general interaction with you. We have still a fair number of questions coming in that we weren't able to get to. One thing that I'd like to tell participants, thank you for participating in the webinar. Those who asked questions and did not receive a response, the Disparities Research Unit staff and Dr. Alegria will work to answer those questions and make sure to send those back to you. When we send you the questions, we'll also do just a brief summary of the webinar and make sure that you have a good sense of what happened during this time. Again, thank all of you for your positive engagement and your excellent questions. They make the research unit team much stronger, and it aligns with the work that they're doing. So those things are actually good to know, that the questions that you're asking are things that the Disparities Research Unit at Massachusetts General Hospital is working on. So thank you again, Dr. Alegria, and the National Latino Behavioral Health Association for the partnership this afternoon, and wishing everyone a wonderful afternoon and a wonderful week. Thank you.